So thank you for this invitation to chat about our experience of quercetin chemoprevention for squamous cell carcinoma in patients with FA. You know, as before I get started, congratulations to Robin and Alex. I wanted to uh, acknowledge their work. And actually, I do have a couple of pens from Alex that I bought at one of the meetings, and they're wonderful. Um, Three things. One of the things that just struck me as Robin was talking about was a couple of words, trust, passion, and hope. And, you know, these are the things that really, as you were saying, and I was thinking to myself that, you know, I am fortunate that patients and parents like you trust me to help patients. And this is my passion, to see if whatever we can do to make things better directly for the patients. Um, and I'm hoping that this talk will be able to bring some hope. So let's start. And I don't know why this is not moving. Just a second. Yep, there we go. So we all know that patients with Fanconi anemia have a 500-fold higher risk of head and neck squamous cell carcinoma um, and other tumors as listed here. Um, it's not only the higher risk, but these tumors, they occur early at an earlier age compared to these tumors that occur at 50 or 60-year-olds in non-FA world. These occur early at age 20, between age 20 and 40. Patients who have been transplanted have an additional 4 to 5-fold increased risk. And most importantly, as most of you may know, is that intolerance of chemotherapy and radiation makes treatment for these SCC in FA quite challenging and leads to poor outcomes in most. I should stick to this. All right. So again, this just shows higher incidence in Fanconi anemia compared to non-FA, significantly higher incidence, much younger age. And an additional feature, which is also important, is in Fanconi anemia patients, we do see second primary tumors. And some of you may be aware of this, is that once one tumor is treated, it's not that we are done, and there might be other second primary tumors. Importantly, the difference that you can see here is that in non-FA, the modality of treatment is surgery, radiation, and chemotherapy combined. However, this makes treatment for squamous cell carcinoma in patients with FA challenging, because surgery, absolutely, we can do surgery, but the radiation and chemotherapy can be hard on the FA body, as we know from the transplant experience. An overall outcome, because of this limitation, remain quite poor. And what this shows you, this curve shows you, that there is a lot of room for improvement. There is a lot of room for research. There's a lot of room for doing things better or different to see how we can conquer this, similar to how much progress we've made in transplanting patients with Fanconi anemia. So this is a huge challenge for all of us and requires a lot of work, and any small bit is going to help. And one of the things that most of you who follow at the Fanconi centers know, that you know, we physicians, we hammer it in early diagnosis, because the key, why it is a key, because that way, if you diagnose early and the tumor is small, then you can cut it out, and then you don't need chemotherapy and radiation. So that's the whole idea of doing the surveillance exams, which are recommended as shown below, where we recommend yearly exams by either ear, nose, throat doctor, ENT, or your dentist, starting from age 10 and starting 1 year after or starting 1 year after transplant. Once the patients reach 16 and above, we increase the frequency of these exams to every 6 months, for a reason, as we just saw, that these tumors happen in 20s and 30s. Similarly, for girls, yearly visits to GYN starting at age 12, 13, um, and close follow-up. Close follow-up is very important anytime if there is a suspicious lesion. Close follow-up, early biopsy. If there is a lesion, early biopsy is the key. We cannot say this is just an ulcer, this is fine, this will go away, as you all know, and that's why you will see that our ENTs will have low threshold for getting a biopsy when it's a patient with Fanconi anemia compared to if it's another patient. For for patients, there are standing recommendations that if you notice an ulcer in your mouth or throat, and if it's not going away after 2 weeks, you need to tell somebody and connect with ENT. If there's a change in voice, if there's hoarseness that's lasting for more than 3 weeks, um, please connect with your physician and do the needful. Um, Early involvement, if there is anything going on, then early involvement with adult ENT partners and oncology partners is helpful, because these tumors, they do um, they normally, we don't see a whole lot of squamous cell carcinoma of head and neck in children. So the adults have a vast experience, specifically in terms of surgery or in terms of novel therapy. It's always a good idea that your physician we touch base with the adult partners. So all this is really simple. It's very boring, and it's hard to keep doing this when you feel fine. But this is what I explained to you. Why it is important is because this is the key to avoid that dismal outcome on that graph. Because once things progress, it's hard to control, as all of us know. So the question is, are there any actionable factors that play a role in pathogenesis of these tumors? And as most of us know, there are many. We've heard of environmental carcinogens, radiation, graft versus host disease, HPV, role of HPV, role of aldehydes, and role of oxidative stress. We try to focus on this particular aspect of oxidative stress contributing to SCC, and looked into it little bit deeper, and we could see that reactive oxygen species is known to play an important role in susceptibility to various cancers, including squamous cell carcinoma. Interestingly, antioxidant quercetin can decrease reactive oxygen species. So that's a great thing. So what is quercetin? And quercetin is a naturally occurring flavonoid or antioxidant, in simple words. And it actually is present in our normal diet. Richest dietary sources include onions, apples, tea, red wine. So essentially, um, we all eat this every day. We just don't eat it in large amount that is required to do something more meaningful, sort of in a medical sense. It is also a common ingredient in dietary supplements or multivitamin preparations. Um, Relatively inexpensive. So the idea is that patients can take this for many years, and in general regarded as safe by FDA. Just to remind you, this is not governed by FDA because it's a naturally occurring antioxidant. It's not a medicine technically. It's considered food supplement. So do we have experience in FA, how the patients with FA will tolerate it or not? So in our phase 1 study, we had used quercetin in patients with Fanconi anemia with marrow failure. And we were able to show that, number one, it is absolutely safe in patients with Fanconi anemia. It is well tolerated when taken over a long time. And number three, most important, we were able to identify an optimal dose so that we can treat patients with the right amount of quercetin. So as we were going through our first study, we asked the obvious question: can quercetin prevent development of squamous cell carcinoma also? And we looked into the literature, and interestingly, there were a lot of data and mechanisms of action in non-FA population, of course, but there were no data in patients with Fanconi anemia. So this is when I call my buddies in the lab and call 1-800 Wells. Some of you may know Souza. She does basic science research on um, FA skin cells and squamous cell carcinoma, keratinocytes, and things like that. And we asked her to look into this and see if quercetin will have any effect on the tumor cells. And Ruby Curry and Souza Wells. Ruby is one of our faculty now, but she was a fellow at the time and working in Souza's lab. And they basically showed that quercetin kills tumor cells in a petri dish, right? And what they were, as you can see here, there is no quercetin. This is tumor cells from squamous cell carcinoma from FA patients. And then you add quercetin and you can see less number of tumor cells. And then you add more quercetin and you can see even less, more further decrease. As shown here in this graph, a stepwise decline. So these are alive cells, so less and less, um, and more tumor cells are killed. And as the quercetin concentration increases. So this was quite exciting. So next thing we asked is, okay, fine, we think quercetin will work, but how does it work? What pathways other than reactive oxygen species will it affect? And in non-Fanconi squamous cell carcinoma, something called as EGFR pathway, epidermal growth factor receptor, is a well-known pathway in the pathogenesis of squamous cell carcinoma. And there are medications that are EGFR inhibitor that are used in non-FA patients. So it was interesting to see that quercetin actually does inhibit EGFR. And we don't need to go into all this detail, but essentially it leads to, at the bottom, apoptosis, meaning tumor kill. Okay, so that was really nice. In the same, Huang et al. Did this experiment, and what they showed is that in mice, when the tumor size in the control mice, uh, when they induce tumors, the tumors kept growing and growing. But when they induced tumors in mice that were getting quercetin, the tumor size remained low, as shown here. You can see the difference in the size, and as shown here, this was the tumor from control mice, and this is from quercetin. So this is showing us that quercetin works on the EGFR pathway, which is really one of the important pathways in SCC. One of the other things that quercetin suppresses is something called as NF-kappa B signaling. Again, you don't need to go into detail here, but there was an experiment conducted very similar to the previous, where here the hamsters that were fed quercetin developed no tumors or very small tumors compared to larger and more invasive tumors in those who did not receive quercetin. So this was really, as we kept looking, it was looking, um, better and better. And we all know that there's a lot of data on role of aldehydes, right? So, and its role in squamous cell carcinoma. So we wanted to see, well, will quercetin affect the aldehyde pathway? And interestingly, quercetin reduces spontaneous, DB-induced, formaldehyde-induced, and acetaldehyde-induced damage in, in lymphoid cell lines that are derived from patients with FA. So that was very much encouraging. And with all these data together, it was really impossible for us not to think of uh, trying quercetin as a chemopreventive agent. And we were actively looking into developing the study to do that. However, just to explain a little bit, is it's very important to define your endpoint, right? If I'm treating eczema, I need to say, well, the steroid cream will decrease, this steroid cream will decrease eczema by 50%, right? However, how do we have an endpoint in a chemoprevention study that is trying to prevent a tumor? Like, we don't know who's going to get a tumor. We don't know when they're going to get a tumor. So how do you prove that what you're doing is actually doing anything, correct? So keeping that in mind, we really were looking for what is called a surrogate endpoint, which is really, really important for these chemoprevention studies. And we definitely needed a reliable and a strong study endpoint. So we worked on a surrogate endpoint of buccal micronuclei in close collaboration with our friends from Barcelona. And basically, Maria and Jordi Surali from Barcelona have shown that patients with Fanconi anemia have a significant increase in micronuclei in buccal epithelial cells compared to the non-FA group. And the micronuclei, you can look under the microscope, and this is that small thing during the cell division, the small remnant stays in the cell, and that's called micronuclei, as shown here. And as shown here, patients with FA had higher micronuclei compared to controls. So this was really great, because we looked into it, and micronuclei actually have been used as surrogate endpoint of cancer studies in non-FA populations. So we were quite excited to have this surrogate marker. The question was, will quercetin have any effect on micronuclei, correct? So we looked at that and saw that quercetin reduced, again, spontaneous, DEB-induced, acetaldehyde-induced, and formaldehyde-induced chromosome fragility as measured by micronuclei in the FA cell lines as seen before. So this was the last piece that we really, this closed the deal for us. And except one other thing additional, sorry. We said, okay, fine, it decreases in some lymphoid cell line, but what about patients? Will it do the same in patients? And from our previous study, patients who were receiving quercetin, we send the buccal sample to Barcelona. Basically, it's buccal brushing, like regular toothbrush that you brush inside of the cheek, 10 times, that basically gets the cells, and then those cells get sent to the lab there. And what we were able to look into two patients, and this is before quercetin and after quercetin, what is the number of micronuclei? And as you can see, there was decrease in micronuclei in both patients. So this was really exciting, and we couldn't hold ourselves back, and we wanted to just start the study, and we hypothesized that treatment with quercetin will reduce DNA damage and genomic instability in post-transplant patients with Fanconi anemia. It will eliminate or delay the development of squamous cell carcinoma by doing so. And so this is where the study came into place. And as you know, some of you have participated, completed participation. Some of you may be taking it. Some of you have considered it and were not able to continue. But I want to put it out here so others who have not heard about it and want to think about it, please feel free to contact our team. So this phase 2 study is still enrolling. A total of 55 adults and or children will be treated with oral quercetin twice a day for a total of 2 years. Um, Out of this, our plan was that 45 will be post-transplant patients with Fanconi anemia, and additionally up to 10 adults, those who haven't needed transplant, but they still remain at risk for squamous cell carcinoma, will also be enrolled. Um, we made sure that we allowed those with history of squamous cell carcinoma to participate, as long as they are not getting active treatment with chemotherapy or immunotherapy or anything like that. So uh, the idea is to assess efficacy of quercetin in reducing buccal micronuclei in post-transplant patients with Fanconi anemia. Along with that, we do additional testing. We do oral exams by ENT, genital exams by GYN, um, blood ROS levels, changes in the oral microbiome, meaning the bacterial load in terms of quality in the mouth. As you know, we all have bacteria and other microbial agents in our mouth. So here's interim results. We enrolled 36 patients with a median age of 14 years. The age range between 6.7 and 26.5. There are 33 post-transplant patients and 3 pre-transplant patients. 17 were males, rest were women. And this is the progress of the study so far. Patients have been on quercetin for a median of about 12 months. The range has been anywhere from 1 month to 24 months. 8 patients are currently receiving quercetin, and 4 new patients will be starting soon. They've already enrolled and consented. 18 subjects have completed 1-year study visit. 11 patients have completed 2 years of treatment. So as you can see, the numbers keep going down. There are 13 patients who are off study. And for various reasons, either they didn't start quercetin, they enrolled, but they didn't start, or they were taken off for medical reasons, needed to, if they were pre-transplant, needed to move forward to transplant, etc. And there were 8 who withdrew from the study for various reasons affecting compliance. Before they withdrew, they had completed a median of about 7 months of treatment, and the range was anywhere from 3 to 17 months before coming off of study. So overall, what do we see? We see that quercetin is well tolerated, even in patients who are post-transplant. That's what we had predicted, but of course we don't know till we actually do it. There were no adverse effects except 10 patients gained weight as expected. We had seen this in our previous study that some patients may gain weight, which for some of the Fanconi anemia patients, it's a welcome change, especially for the parents. Um, and out of these six, we couldn't tell. The results are clouded by the physiologic weight gain, the growth spurt, because some of them were young adolescents, so they're going through the growth spurt, they're gaining weight. So you couldn't say, oh yes, quercetin, they gain weight, great. However, in 4 patients, the weight gain was related to quercetin only and not confounded by other physiologic factors. Again, this weight gain and growth, everything is monitored by our endocrinologist on the team, and he decides if the weight gain is attributable or not, and not me. But again, this is what we found. A median weight gain of 5.8 kilograms following 2 years of quercetin therapy in those who have finished 2 years, right? And the range was anywhere from 4 to 13.1 kilo. 2 patients had stable weight, and 1 patient had, with clinical depression, had lost weight at 1 year. However, after therapy, her weight is back on track. An interesting thing about this is we're still trying to figure out if there are what reasons, what is driving this. And clinically, um, what I feel is what we've seen and when we've talked to the parents is that it increases your appetite. And after the appetite is increased, we need to decide what kind of a choices we are making for food. So that will decide how much weight gain. So we've seen differences based on that too. The other thing was, the most important thing was the frequency of micronuclei. Are we able to do any damage there? And in 14 patients with available results, we have the mean frequency. It decreased from 3.8 to 3.5 after 12 months of quercetin. This is only 1 year data for 14 patients. And if you look at it left and right, you can see that there's decrease on left is more and right is, stable to slightly increase. And that what made the total decrease slightly lower. Importantly, for those patients, 8 patients, where we did see the MN decrease, you can see how much decrease we saw. So these are we only had data on 7 patients on from the left side. These assays are not are the assay itself is not difficult, to somewhat difficult, but Barcelona team has mastered it. But it's the collection of sample and transporting across the globe. All that, sometimes we don't get enough cells, and that's why we don't have, like 1 patient, we don't have enough 8 left-sided samples. You can see on the left side, there's 37% decrease, right side 13%, and overall was 35% decrease. So this is really exciting for us. We looked at PB Ross, and we had shown these data before too, when we only had 6 patients. And Ross basically remains relatively stable over time. Do we see changes in the microbiome? This is something that we've talked about in FA community before, also the role of microbiome. And we were very interested to see what happens after quercetin treatment. Now, these are early preliminary results that I'm sharing with you. So we'll see how this pans out. But just to put things in perspective, in this graph, basically, this is called a PCT plot. And here, blue are the control, and the orange is baseline FA samples. First thing we wanted to see is there a difference in the FA microbiome compared to the control non-FA microbiome? And in this plot, basically, things that overlap are similar and things that move away from each other are different. So this shows us that, of course, the FA microbiome is different than the control microbiome. Um, Here, it's the same thing, statistically significant differences in different types of bacteria between control and FA. So again, these are just baseline changes, FA versus control. Blue is the control patients and orange yellow is the baseline FA patients. Um, we see significant differences in genus abundance between baseline and 6-month post-quercetin treatment. So I've shown these things before. These are baseline orange and 6 months. So now we are comparing FA to FA, right? We're not comparing FA to controls. These are the patients pre and post. Are we seeing any difference? And you do see that there is baseline compared to the 6-month, there is definitely differences. There are certain species of microbiomes that are going down, and there are certain species that are increasing in abundance. So now we have samples with the study on certain patients up to 2 years. So we compared and we saw that, as I showed you, I told you before, when there is overlap, they are similar. When they are far apart, they are different. So here, basically, this 24-month red circle is very different from the baseline, this blue circle. So it tells you that these things, composition at 24 months is quite different. And you can actually see the path that it moves from the 6-month to 1 year is change, and then 1 year to 2 year is a change. Um, what this here, you can see many species and metabolic genes are significantly enriched. So the blue is the baseline, and then at 24 months, 2 years, you can see significant increase in certain species compared to baseline. And these are metabolic genes between baseline and 24 months. And I don't claim to understand this. Our infectious disease team, who is we have partnered with, is analyzing these data, and these have just come, and you won't believe, last night. So we will look into it, but there are definitely certain things that look very different at 24 months. Just to give you 2 examples, these are 2 bacteria that are commonly seen. These are called commensal organisms that are significantly enriched at 24 months compared to baseline. So this is Haemophilus, this is Neisseria that normally are seen. We are analyzing the data to see what it means, but so far this is what we see. Seeing more normal um, in my mind is a good thing, but again, these are very preliminary data. We will look at it in more detail and try to, as we have more patients coming through for 24 months, it will be really interesting to see what difference we are able to make. So in conclusion, our interim results demonstrate that quercetin therapy is well tolerated. It leads to improvement in surrogate markers of DNA damage in the buccal mucosa, i.e. the number of micronuclei in patients with FA. Similar to our previous study, weight gain was observed in a subset of patients. Quercetin also leads to changes in the oral microbiome, as I just showed you. Um, As expected in a study where prophylactic oral medications need to be taken twice a day for years, compliance remains challenging, as I showed you the data. Having said that, these are the first results of a novel, multifaceted, targeted chemopreventive strategy. It targets reactive oxygen species, it targets EGFR, it targets NF-kappa B, it also targets aldehyde. So we are quite happy that we are able to show positive results with this quercetin. Our goals for near future are the most important goal would be, of course, continue the enrollment, but more importantly, to address the compliance in an attempt to improve this issue. And again, this is a common thing in medicine. Nobody is 100% compliant, but can we do better is the question. So to improve this, what we've done is we've amended the protocol a while ago to include compliance. So if we have patients who've not been able to continue as expected or didn't take it for at least certain time, we won't be able to use their data. So that is the downside in a rare disorder. As you all know, if you take the drug for 2 years, but if you had a lot of gaps and you didn't take it enough, and if I can't um, include you in the analysis, then it's a little bit of a challenge. And it's, I don't want, when people have gone through the trouble of taking the drug, I don't want to lose their data to help come to some meaningful conclusions. So we've adjusted the protocol accordingly. We are also working with our psychology team, who's already part of the study, because they are the ones, they decide the compliance. I don't decide the compliance to avoid bias. And they specialize actually in adherence. So with their help, we are trying to make some few changes to see if we can make this better for all of you. Introducing electronic drug diary rather than a pen and a paper, because the paper may get lost, or you didn't take it when you were out with friends, but the phone is always there nowadays with everybody. So we are hoping that this would help. Also, electronic reminders is something we are considering, and other incentives. So I would really like to know if you have any suggestions. Please reach out, or please, we can have a discussion even now if time permits. But we'd really appreciate if you guys have any suggestions. We do understand that the powder form has been challenging for some people. Unfortunately, that part, we cannot change the formulation in the middle of the study. And this is what we have the track record with. So it's hard to change that piece right now. So, but if you have any other suggestions, please chime in. And last but not the least, I wanted to thank Fanconi Anemia Research Fund for providing the seed funding for this study. Initially, that led to R01 funding from FDA, and also R01 equivalent funding from Gateway Foundation. Thank you to my Fanconi team at Cincinnati and Barcelona friends, Jordi and Maria. And most importantly, thank you to all of you. And I sincerely mean it, to patients and their families for trying your best and participating and trusting us and helping us, carry forward these trials.